The drug therapy for peptic ulcer disease is covered under gastritis, so we will go to a previous page when we get to management. Okay. So what are peptic ulcers? There are two peptic ulcers. We have duodenal and gastric ulcers. Gastric, obviously, where is the ulcer? In the stomach. When we say duodenal, it's in the duodenum. There are other forms of ulcers. We have Curling's ulcer, we have stress ulcers. They are different from peptic ulcers. Those are also caused by other other factors. What are ulcers? So just like a what is that? How do you define an ulcer? Okay, so there's a there's an yeah there's a right there's a opening on the mucous membrane, correct? Okay, so if you have pressure ulcer, then there's an opening on your skin. Okay, so it's an ulcer, so therefore it's like a crater, right? So you have a crater. There are two most common forms of, causes of peptic ulcers. One is H. pylori, the other is chronic use of NSAIDs. Okay. Please take note of the first statement. What does this say, Kurt?
In the past, stress and anxiety were thought to be the cause, but now it isn't.
Okay, so before we thought peptic ulcers were caused by stress and anxiety, meaning we thought, if you have, let's say, a type A personality or you have a high stress job, you work in Wall Street, so you'll see those depicted in movies, right? They carry Pepto-Bismol and they drink it when they have problems, involving a lot of money. So they, or even in movies where I see cops, like the police captain, for instance, is very high stress because a crime wasn't solved, and you see them in movies taking Pepto. Okay, so that's just for Hollywood. Okay, so here, is it really caused by stress and anxiety?
No.
Okay, no. What is H. pylori? So this is Helicobacter infection. It's a bacterial infection. It's very common anywhere. We may have picked them up at some point in our lives, but they lie dormant inside our GI tract. They don't usually cause problems until we meet certain criteria. Because describe the environment in your stomach. If you were to live in there, let's say, imagine, John, that you are a bacterium, you are H. pylori, and you're able to withstand that environment and live there, and yes, and then cause problems there. What can I say about you? You're badass, right? You're pretty strong. Okay. Here's the other cause. It should be chronic use of NSAIDs. We'll be okay if we take it occasionally, you'll be fine. Who are these people that will have to take it regularly and for a long period of time? Chronic pain, like what types of chronic pain specifically? Okay, usually arthritis people, osteoarthritis or rheumatoid arthritis, inflammatory type pain. Some are similar conditions, let's say lupus, for instance. They also have joint pain. Multiple sclerosis patients, they take NSAIDs as well. So how does it do it? What is the action of NSAIDs? How does ibuprofen heal pain? How does it relieve pain? What does the drug book say is the mechanism of action? They inhibit what? Prostaglandin. Okay, so it inhibits prostaglandin synthesis. What is prostaglandin? Prostaglandin is there are different types of prostaglandin. Most common type is it's a neurotransmitter for pain. So therefore, if you inhibit it, then there is no pain, correct? However, it's also a potent vasodilator. So therefore, if you inhibit it, what will happen to microscopic capillaries that depend on it for dilation. They cannot dilate, right? So they will constrict. And then what happens to the tissues that they are supposed to supply with blood and oxygen? Okay, so we're talking about your kidneys. The nephrons are supplied with microscopic capillaries, correct? What else? Your heart also has microscopic capillaries, right? And then finally, your GI tract, the cells that produce mucus, the mucus producing glands or cells in your GI tract depend on prostaglandin. So as a result, if you take NSAIDs for a long period of time and then frequently each day, what will happen to those three organs I mentioned? GI tract, the heart, and the kidneys. Okay, there will be injury to those three organs.
So can you repeat the function of it?
One is for transmitting pain impulses. The other is it's a potent vasodilator. Other risk factors are smoking and alcohol consumption. You also have family tendency. Let's go now to the pathophysiology. So what's the most common cause again? H. pylori infection. So we picked them up. No, let's say you violated the 5-second rule, right? You dropped your donut. A little over 5 seconds later, you picked it up and put it in your mouth. Okay, so that's how you got H. pylori. Then it sat there just waiting. Okay, just waiting until there's a disruption in your normal flora. Because remember, most of our immune system bacteria are in our GI tract, correct? They protect us. So let's say you're drinking alcohol or you got sick, you got really immunocompromised, and then the number of bacteria got disrupted. Okay, so now the H. pylori has a chance to take over and cause problems. And then that's what they do. They burrow into the mucosa, causing the ulceration. And what's the purpose of the mucus lining in your mucosa, in our GI tract? Why? Because we have pH between 3 and 6. That's very, very acidic. So how come our stomach, our intestines are not damaged by these acids? These acids can liquefy chicharron. They can change anything solid to liquid. So you can just imagine the corrosiveness of our stomach acids. How come our stomachs can withstand that? Because of the mucosal lining. We have mucus all over our GI tract. So therefore, if you have ulcers now, what's covering those ulcers? Nothing. There is no mucosal barrier. So therefore, what happens if they're exposed now? You put acidic juices there on the ulcers. What will happen to these ulcers? Very painful. So now plus there are exposed blood vessels now, right? You put acid over arteries or veins. What will happen to those blood vessels? Rupture and then bleed. Okay, so we'll talk about bleeding as a complication of peptic ulcer shortly. So it can either be caused by pyloric infection or chronic use of NSAIDs. Let's go to the manifestations now. How can we differentiate if the ulcer is in the stomach or in the duodenum? Before we get to that, we will have to look at the symptoms. So let's review our physiology. When we eat, how long does food stay in the stomach? 1 to 1.5 hours. What does it do? What is it doing in the stomach while it's sitting there? Okay, so your stomach is turning it into liquid, right? So your pepsin, gastrin hydrochloric acid are being secreted, turning anything you eat into liquid. Once in its liquid form, 1 to 1.5 hours later, it moves to the duodenum. Okay, duodenum is now ready to receive it. It's now liquid. Okay, it will absorb all those nutrients, and then final water reabsorption, of course, goes to the colon. Okay, it happens in the colon, and then you have a bowel movement. Okay. Because of that physiology, imagine you have stomach ulcers. When will the pain be experienced? Because now you have gastric juices. I eat now. When will I suffer the pain?
About 30 minutes.
Okay, so right here, the pain associated with gastric ulcers occur when? Immediately after eating. Whereas duodenal ulcers, when will the pain be felt? 2 to 3 hours after meals. Does it make sense? Okay, because when will the acid enter the duodenum? Okay, about 2 to 3 hours after eating. That's when the chyme, the gastric contents, enters the duodenum and then exposing the duodenal ulcers to the acid. But both will report these sensations: dull, gnawing pain, mid-epigastrium or back. And of course, in order to definitely make a diagnosis, the patient will have to undergo an EGD. What is an EGD? What does it stand for? What is that, those initials stands for?
Gastro.
Esophago gastroduodenoscopy. Okay, all right. Yeah, close enough. What are your responsibilities when you have a patient going for EGD tomorrow? How long? Yeah, after midnight. Okay, so they have to be NPO for 6 to 8 hours. Do I need to give them any bowel prep? Like, do I need to give them laxatives or an enema? EGD?
No.
No, just NPO, that's it. NPO only, okay? If it's a colonoscopy, yes, you have to clean. It's gonna be dirty because you have to give laxatives, and depending on if your patient is mobile or not, it's gonna be a mess, okay? It's gonna be pooping all night because you need the output to be what? For colonoscopy.
They have to be clear. It's the liquid.
Yeah, it's not really the amount. The basis of when you stop, how long you do the bowel prep is not determined by the amount, but rather than the characteristic of the output. What do you want the output to be? Clear like tap water clear?
Like brownie clear. Brown. Like brown.
Brownie clear. So remember, what are we trying to do? What is the doctor wanting to do?
They're on the mouth.
Because they want to do what? They're gonna put the scope up your rectum to your sigmoid and up to your colon. How can they do that if there are feces in there? They can't do that, right? Okay, so therefore, what kind of output do we want to see? And then we can conclude, all right, the procedure is okay to proceed because output is now clear. So how clear are we talking about here? Free of fecal matter. All right. It will never be tap water clear because, I mean, this is the colon we're talking about. There will always be some bits and pieces of feces in there, right? But we don't want anything solid. All right. What if my output is, you know what chocolate soup is? No. Never had Filipino dish, you know, our we make either pork or beef blood soup. No, you don't know. Okay, the closest thing I can, no, should be thick.
It's like that brown water.
Okay,
Like the book.
You know what porridge is? Porridge?
Yeah.
No, chicken soup is too thin. But anyway, if it's not clear, meaning if there's still some color to the output, like brown, you can tell it's brown, that's not clear. All right, what do we mean again by clear? Free of fecal debris. Okay, fecal matter, there are nothing solid there. It's okay again to be a little cloudy, all right, but it's pretty much should be clear, free of debris. All right, because otherwise, now this is important, guys, because what will happen to the procedure? Can they proceed? Is it going to be successful? No. And remember, we are working for the hospital. This is a money-making business, okay? So these procedures cost thousands of dollars. So if the procedure can't happen because you did not prepare the patient, did the hospital lose money? And how does that translate to our benefits and salary increases potentially? Okay, so you have to care, all right? So all of these schedule plus that's just the business side. Did the patient need this procedure done? Yes, we needed a diagnostic or therapeutic procedure in order to find cancer or stop bleeding. These are the usual purposes of a colonoscopy. Either diagnostic or therapeutic purpose. There are other manifestations associated with it. Indigestion or dyspepsia, abdominal pain, diarrhea, constipation. Number one and most fatal complication, of course, is bleeding. Bleeding can be upper or lower bleeding. So it's upper bleeding. How do we know? Okay, so the patient will vomit either bright or dark red blood, or if it's sat there for a while, it will appear coffee ground. You know what coffee ground means? You've seen coffee grounds, right?
Yeah.
After you put coffee, the grounds, the granules that are left, that's coffee ground emesis. Okay. That's what it looks like if the bleeding is a few hours old in the stomach. Now let's review how do we know it's lower GI bleeding? What does it look like?
Brown, black.
Okay, black. Okay, black tarry stool means upper GI bleeding, right? That came out through the rectum. It can also be bright or dark red if it's a lower GI bleeding. Bright red means it's an arterial bleed. Dark red, then that's a venous bleed. There are other complications. We have a table later. Already explained the physical exam, how we diagnose peptic ulcers is we have to have an EGD. If this can't be identified with an X-ray or ultrasound, has to be an EGD. The doctor has to find and visualize the ulcer, okay, in order to make a diagnosis. Once they see it, they will always get a biopsy of the ulcer to check for the presence of H. pylori. And we'll get to the management shortly. During the EGD, if they see any active bleeding, they will go ahead and stop the bleeding if possible. If it can be done endoscopically and doesn't require surgery, then they'll do it right there. Okay, they either cauterize, you know what cautery is? Like you'll solder, like burn off the bleeding capillaries or small blood vessels. If they're too big to cauterize, then patient will undergo open abdominal surgery. Management. As I said, we will look at the pharmacological list under gastritis, and I'll go back here. All right. Let's go to gastritis first. These are the list of medications that will be given to patients with peptic ulcer disease. There are 4 groups of medications. First are antacids. What are antacids? Tums is a calcium-based antacid. What else do you know? Maalox. We have Maalox, which is magnesium-based. Okay.
Gas X.
Then we also have aluminum-based. Okay. Not sure what Gas X. No, Gas X is not an antacid. That's simethicone. That's for gas. So what do antacids do? Whether it's calcium, magnesium, or aluminum-based, they neutralize the acidity. Okay. Next group of drugs are H2 receptor antagonists or H2 blockers. What are examples of these drugs? Famotidine, cimetidine. Ranitidine is no longer in the market. That was already taken off by the FDA. Then we have proton pump inhibitors. These drugs end in Razole, okay? Razole, omeprazole, pantoprazole, lansoprazole, esomeprazole. What's the difference between H2 receptor blockers and PPIs? Both decrease acid production in 2 different ways. Another difference is the duration of action. H2 receptor blockers, maximum action is 12 hours. PPIs, 24-hour duration. So off the record, I really don't know why these are still on the market, because PPIs work better, correct? Do exactly the same thing and is more efficient because it lasts for 24 hours. These drugs only for 12. So what's wrong there? Okay, so it's all about business. So again, I don't know, since we discovered PPIs, there's really no need for H2 receptor blockers. No, you can be on it for indefinitely. The only contraindication for PPIs is if you have osteoporosis. Then you will be taken off PPIs and then put on H2 receptor blockers. Osteoporosis. Because PPIs cause osteoporosis. Has something to do with calcium absorption. It didn't specify which one, just said PPIs. Okay, let's go back to peptic ulcer medical management. There's a table here now. It's a drug chart, so what do I ask you? All right. What does this say here? This is for peptic ulcers, okay? So if you're using the drugs for other purposes, this is not what you refer to. Are we clear? This is only for peptic ulcer treatment. So these are the dose. I'm not testing you the dose because the doctor will decide the dose. But this is the period for acute peptic ulcers. So you have 6 to 8 weeks and then maintain after a year. And these are the PPIs, 4 to 8 weeks. So it's either or, okay? The doctor may put you on H2 receptor blockers or PPIs. What's the purpose for this therapy? Ulcer healing, okay? Next, if your ulcer is caused by H. pylori, then it will involve, because it's a bacterial infection, so it will now involve antibiotics. Now, how did I describe John? John is a H. pylori. How did I describe him? Badass. So how many antibiotics will I give in order to kill him? At least 2. Okay, you can have 3 in some instances, but 2 usually is the prescription. What is the third? The patient may receive a PPI, okay, or a H2 receptor blocker. So again, 2 antibiotics and 1 PPI or H2 receptor blocker. Or we can have quadruple therapy. Now we add Pepto. Bismuth subsalicylate is Pepto-Bismol. Then this is the combination. Tetracycline with metronidazole twice a day, and then the PPI. So this is the quadruple therapy. And this is the triple therapy. Clarithromycin, amoxicillin, or no, this is still quadruple, sorry, because this is all quadruple. So you can have 3 antibiotics, clarithromycin, amoxicillin, and flagyl, plus PPI. A question?
Yeah, with the bismuth salicylate. Pediatrics for bleeding. How do they do that?
Actually, when you combine it here, although this contains aspirin, correct?
Mm.
However, this will act like a coating agent. It will coat the ulcer, protecting it from the acid.
It doesn't expose them for risk of bleeding? Not a potential.
Not in this current combination, no. But yes, it does contain aspirin. Yes.
So you think that the Bismol in that case for what? Anti-acid?
No, this is for coating the stomach. We'll have more when we get to the mucosal barrier fortifier. It will be mentioned again. If you're somebody who has to take NSAIDs because you have nothing else to take, nothing else works for your pain. Let's say Acelina has very, very bad osteoarthritis. Okay, so her knees are just cracking. She can't walk without pain, right? And she's not a candidate. She chose not to have knee replacement, for instance. So just tough it out with the pharmacologic management. Okay, she doesn't want to have knee replacement. So to protect her, her doctor will prescribe misoprostol. Have you heard this on the news?
Yeah.
Okay, so it became
Yeah.
right. So it became very popular ever since Roe v. Wade was overturned, right? I mean, it's already been around. We're not like advertising this thing, we're not putting ads there. Oh, birth control here, misoprostol. It's just not ethical, correct? But it's been around for a long time. Now, originally, the purpose is not really for abortion. This was the original intent of the drug. This is called a prostaglandin analog, exactly for the purpose of protecting or preventing ulcers in patients who have to take NSAIDs. Okay, so this is what the intention of the drug. But they discovered that when pregnant women took it, it caused an abortion. So they figured, here's an off-label use. Okay, here you go for abortion. Somebody had a question? Yes.
So what would it do in men?
You want to have people have an abortion.
I don't man can't carry babies, but like.
What was your gender assigned at birth? Okay, yeah, no problem with it.
You're gonna be sterile. You're gonna be sterile, you can't have kids.
No. All right. Any questions so far before I proceed? Okay, so these are just for peptic ulcers, all right? So we've covered the 2 most common causes of peptic ulcer, which are H. pylori and NSAIDs. Yes.
What medication Zofavir?
We'll get to that. And yet we already discussed this. Okay, so none of that. Now there's another drug which John mentioned. Okay. So here. as an alternative to Pepto-Bismol, so let's say like Miss Kalu has concern about Pepto because it has aspirin. A patient has a history of GI bleed, or let's say very elderly, a high risk for GI bleed. The alternative is to use sucralfate. Sucralfate is a large tablet which you chew. You can take this 4 times a day. Do you take it before or after meals? The purpose of the drug is to coat the ulcer before meals, and then the fourth one will be at bedtime, because you know we still have gastric acid secretion at bedtime, correct? So that will cover you for the hours of sleep. All right, again, 4 times daily. How long before a meal? Knowing that food will stay in the stomach for 1 to 1.5 hours. Okay, 1 to 2 hours before a meal. Okay, way in advance of the meal. That way it has a chance to, because remember, it has to sit in the stomach, and then before it proceeds to the stomach or the duodenum. Are we clear? Okay, 1 to 2 hours before a meal, and then at bedtime. Okay. This will help smoking cessation, because what will smoking do to acid secretion? It stimulates and promotes acid secretion, so that will not help. So smoking cessation should be encouraged. Diet modification. Now, look at it here. There's really no diet that will heal an ulcer. Are we clear? There's no diet that you eat that will heal an ulcer, because everything you eat will stimulate what? Acid secretion. All this is saying is, if something causes discomfort, the food causes discomfort, what do? Don't eat it. Okay, as simple as that. Other foods definitely off the menu will be those that will overstimulate acid secretion or irritate existing ulcers. They are the following: alcohol, coffee, yeah, again, anything that will, if spicy food is okay with you, eat it, right? Again, anything that will cause discomfort, don't eat it. But I mean, spices, Frank's Red Hot, Tabasco sauce, what will that likely do?
Irritated.
Yeah, I don't think that will ever, come a time wherein it's okay. I don't feel anything. Of course, those spices will, those hot sauces, of course, will burn. Please take note of these also. So it's not really true that small frequent feedings are necessary in ulcers. Okay. Medications will help promote comfort. Again, I repeat, patient eat foods that are tolerated and avoid those that cause pain. If needed, let's say the patient now has a perforated ulcer, meaning they didn't comply with therapy, continues to eat whatever they want. Now the ulcer got worse. Remember, the ulcer is now bleeding, correct? And can it burst?
Yeah.
Yes. Once we have a perforated ulcer, so now there's a hole in your stomach or in your duodenum. What will come out into the sterile peritoneum? Doo-doo and food and acid. Okay, remember the GI tract is it sterile?
No.
No, the GI tract is not sterile. But what is the membrane that houses it? Is sterile. The peritoneum is sterile. The GI tract is not. So if there's any perforation, what will it do to a sterile cavity? Okay, what do we call that condition now? When you have peritonitis first, and then they will go into shock. Okay, and then go into sepsis, sorry. So peritonitis, and then you become septic, and then you know the rest from module 1. How do we diagnose perforation? CAT scan. So we will look at CAT scan. Is there air in the GI tract? Yes, I just passed a few early this morning. Is there air in the peritoneum?
No.
No, there shouldn't be any air there. What will it mean if we see air in the peritoneum?
Leakage.
It had to come from a hole somewhere in your GI tract. Are we clear? All right. And depending on how big that hole is, if it's small, if the air is small, that means the perforation is small, correct? So if that's the case, they'll just put you NPO, give you antibiotics, and then wait for it to close. If it's, however, significant, more than a few centimeters big, then you will have immediate surgery. What will happen to you in surgery? Well, what kind of surgery they'll do depends. How big is the perforation? How many are we talking about? So if it's just small, let's say 1 to 2 inches, they can re-anastomose. Okay, so they'll cut a section of your bowel and then reattach the remaining ends. What if it's a significant size? So let's say it's more than a few inches. Can you? No. So now you will end up with an ostomy. Okay. I won't test the surgical procedures, so you can skip table 40-4. Let's go to the next table, which is your complications. There's no table. Okay, so all right, there's no table. So let's do the paragraphs. First is hemorrhage. So we already talked about hypovolemic shock. So what's the plan if it's GI bleeding? What do you give first? Followed by blood products. Okay. What else will be given? Because remember, what's the cause of the bleeding? Why is this bleeding? Well, not yet. The patient is bleeding. Why? What happened to the ulcer?
Burn.
Burn in the blood.
Well, not necessarily burst, because that's perforation already. We're just talking about hemorrhage from GI bleed. So meaning the ulcer exposed some blood vessels, right? And those blood vessels are bleeding. So how do you stop it? PPI will have to be part of the therapy. One-time dose or continuous? Okay, it will actually be both. You give a bolus of dose of 40 milligrams pantoprazole, and then followed by a continuous drip. So that will keep the acid down. So technically speaking, when you give a continuous IV drip of a PPI, what is it doing there for? What is it? What's the purpose of the PPI therefore? To stop or prevent the bleeding, because the bleeding will eventually stop, right? Remember, we have hemostasis, right? We will stop the bleeding. Remember that clotting cascade? However, if you give PPI, will it stop it from bleeding again? Yes, that's the whole purpose of the PPI. One more thing, one more drug to be used. This patient is bleeding in a sterile or a dirty cavity? A dirty body system. So what will be given as well? Okay, the antibiotic of choice will be metronidazole. Okay, it's a common GI antibiotic.
What is lower the infection probability of the patient? I mean, increase the infection probability.
What will the bleeding?
The PPI bolus.
How though?
Bring down his stomach acid. So that they can,
Well, it's not like the stomach pH will become totally alkaline. No, it'll just decrease the acidity. So again, let's summarize. So fluids first, blood products when stable. When the blood pressure is stable, okay, we give blood products, and then PPI, and then metronidazole. Okay. Oh, what will be inserted? Let's say it's a upper GI bleed. NG tube. What's the purpose of putting in an NG tube?
Bypass the function of and
Is it better to vomit this or to suck the blood out? Okay, it's safer to suck it out, right? Because if you allow the patient to keep vomiting, can they aspirate eventually? Yes, patient may have a decreased level of consciousness, and those patients vomit, you'll have aspiration for sure. So we put an NG tube, so that will help decompress the stomach, prevent vomiting in the first place. Then, of course, watch for shock, okay? Hypovolemic shock. You already know the signs and symptoms and the stages of shock. So this could be your hypovolemic shock patient, right? Someone who has a peptic ulcer. So we discussed already the shock management part. So this is now the GI bleeding part, okay? This is how you manage it. We only send the patient, let's say the doctor decides to do a EGD. They will only be sent to EGD, obviously, when stable, okay? When stable enough. That doesn't mean, of course, they still need the EGD. We need to stop the bleeding, but we can't, because what will the procedure entail? You will have to give the patient, well, the patient's NPO regardless. The patient will require what? Because they're going to put a scope down your mouth.
Yeah, so you need thunder.
And anesthesia, right? So can we do that if the patient is not stable?
No.
Okay.
You drop your foot.
Okay, we already did chapter 11, hemorrhagic shock or hypovolemic shock. Okay, let's go to perforation and penetration now. So the ulcer burst caused a hole in the stomach or duodenum, and now fecal or food matter is now in the peritoneum. How do we know the patient now has peritonitis? Here are your manifestations. Because perforation, will it most likely lead to peritonitis? Yes, that's the inevitable result, right? So when we say perforation, don't stop there. Always consider, well, there's a hole. So all the fecal and food matter is going to go into the peritoneum now. So I know my patient who is high risk for sepsis. Peritonitis first though, and then sepsis. So these are your manifestations of peritonitis. Now, these manifestations will not be all over the abdomen at first. It will just involve one section initially. Okay, so let's say Acelina's gastric ulcer pop. So stomach is over here, correct? And because the most ulcers are in the antrum, so the perforation will be most likely here. Right? So her mid-epigastric area may be the first one that will feel board-like and rigid. Okay, this will be the first section. And as the peritonitis spreads, then it will involve other areas of her abdomen. And what are these signs and symptoms of?
Bleeding.
Shock. Okay, yeah, bleeding and then shock. Okay, we already discussed the NG2. Do you know how to calculate INO when there's an NG tube? Say I put a question there and have you calculate, one of your math questions to calculate output from the stomach.
What are you asking me to pull it out?
Okay, let me describe. So let's say this is Acelina. She has long hair. She has an NG tube. And it's connected to a wall suction. Okay. And this is, let's say, there are numbers here, there are lines here. And this is, of course, inside her stomach. She's not pregnant. This is her stomach, okay? Just use your imagination, okay? So this is the level of, we have green here, green gunk, and some yellowish, okay, coming out of her stomach. At 7 a.m., it was empty. And let's say this is around 700 ml there. That line is 700 at 7 p.m. It is now 7 p.m. Time to empty and record your your output. During the shift, remember the NG tube, you know what a Salem sum tube looks like? Have you seen these tubes? Okay, this is what we call a Salem sum tube. This is not for feeding. Are we clear? This is not a feeding tube. This is a nasogastric tube for suction and decompression. Technically, yeah, if we want to, let's say, but it's not for feeding, okay? Let's say I need to give contrast, for instance, and the patient vomits, they can't drink it. So this is an option, okay? But really, it's not for feeding. Are we clear? This is to decompress the stomach. So we put it in, and then we attach it to suction or put it to gravity. At 7 a.m., it was empty. Now 7 p.m., it's at 700. During the shift, because the tube has holes, correct? It has holes in the end. Right here, there are openings. Remember in chest tube, we talked about eyelets? Yeah, same thing. Okay. So this thing has eyelets here on the tube. This will be in the stomach. So this is where all the contents will be sucked through and then come out the other end. Right? It got clogged because she's bleeding. Obviously, there will be some clots there, correct? So I had to do what? In order to clear the eyelets, because there's some blood clots there, it's not sucking anything anymore. So what do I need to do? Flush it. So I'll disconnect it briefly from the suction and then attach a syringe and I'll flush it to clear the blood clots. Right? Reopen my eyelets and then I reattach it to suction and it started working again. Right? So the suction here will just be low intermittent suction. Are we clear? LIS. You don't put this thing in continuous suction. only low intermittent suction. So at 7 p.m., we're at 700. Throughout the day, it got clogged 4 times. I had to irrigate it 4 times with 60 ml each time. Because 30 wasn't enough, so I had to irrigate it with 60, enough to open my eyelets, and then it started working again. So the damn thing got clogged 4 times, and I had to flush with how much? 60 each time. How much will I put for my output, NG output for the shift?
You put in 240.
No,
No,
460.
520.
Do your math properly.
3 times.
I put 60 4 times.
Oh, 4. I hear 3.
460.
It's, yeah, 460.
Okay, so my total output is
460.
460. Why 460?
Because of 45.
Okay, so 700 minus 240. Where did the 240 come from? Hey, it didn't come out of the patient. Remember, I put it in there. All right, I put it in to flush the to unclog my tube. Are we clear? All right, so that's how you calculate output.
Well, what if you didn't flush it, and it's the whole 700, and that's a.
And that's your output.
Okay. So what do you use in flushing? I mean, is it normal saline?
I mean, do you drink normal saline?
No.
Water, tap water is fine. You can use sterile water, but do I need to?
No.
I mean, I don't drink sterile water. I drink
Level.
tap water, yeah. Ask the patient, what do you want? You want
Ginger ale.
vitamin water? What's that expensive one? Essentials? or-
It's actually, I forget.
Want Fiji? A patient has prefer. Okay, I want Fiji. Okay, where's your Fiji water? Okay. Whatever they want. Okay, let's finish the complications. We have gastric outlet obstruction. Here are the manifestations. And this is your treatment. So when we have gastric outlet obstruction, NG tube again. And the doctor will perform a balloon dilation via endoscopy. That's about it.